I'd like to welcome Karen Eliav. Karen has a wealth of occupational therapy experience. She is an occupational therapist specializing in infant treatment here at Seattle Children's Hospital, and she's been at the hospital for 10 years. She is certified in neurodevelopment treatment, infant massage, and as a lactation educator. Karen has specialized training in infant feeding practices and has worked in other high-level NICUs throughout her career, including New York University Medical Center in New York, Valley Medical Center in Renton, and Overlake Medical Center in Bellevue. And she's passionate about partnering with the NICU team to assist in helping patients navigate their journey to well-being. Please welcome Karen.
Thank you. Thanks for coming. I see many friends in the audience and hopefully at other places as well. So I'm really excited to be here and to talk about feeding. Feeding is obviously a passion of mine. It would have to be to do my job. So what I wanted to do today is talk specifically about feeding through a developmental lens. One of the challenges of this presentation is I want to make sure to cover some of the basic components of feeding for new therapists or new nurses while still getting a little bit more in depth for those of you that are pretty familiar with some of those basics. So what I decided to do was talk about developmental principles of feeding within the context of 3 case studies, 3 different babies that I've been able to work with over the past year to kind of share a little bit of that developmental insight that we think about when working with babies. I don't have anything to disclose. And these are some of the objectives that I hope to achieve today, being able to describe the components of feeding, strategies to improve oral feeding competency in these infants, and also to be able to identify some of the disengagement cues that happen during feeding. So I am up here alone, but I am definitely not up here alone in the bigger sense. This is my team. We are getting so big it's hard to get everyone in one picture, but I work within a team of occupational and physical therapists here at Children's that serve the infants from birth to age 1 throughout the hospital and also in the outpatient setting. It's really such a pleasure to have that as my home base, and I think it helps me, I know it helps me to kind of thrive in this setting. I'd specifically like to thank Lynn Wolf for contributing some of the slides for the presentation and for her support. So let's get started. Feeding. Feeding is clearly the most challenging task required of an infant in the NICU. Before they're ready to feed, the baby has to maintain their temperature, has to pee and poop, and kind of stay with you with their appropriate vital signs. And then afterwards, we ask them to do all of those things in addition to a really complex neurologic task. It definitely involves a dynamic relationship between the infant and the caregiver during feeding. And we know that early feeding experiences really lay the foundation for future feeding skills for the baby and can have an impact on the parent-infant bond. So I mentioned those 3 babies that we'll talk about. Just briefly, the first baby is Lauren. She's a 30-weeker with minimal respiratory support, and mom strongly desires to breastfeed. The second baby is Sophia, who was born at 31 weeks. With emergency C-section, she needed ongoing ventilatory support and ended up having a VP shunt placed. And then the third baby is Arjun, who's a little bit of an older baby at 36 and 6 weeks. He was a twin who needed a minimal medical intervention, but needed a NICU readmission. So we'll kind of go through these babies. And we'll start with little Miss Lauren. So as I already mentioned, she was born at 30 weeks via vaginal delivery because of premature rupture of membranes. She needed CPAP briefly after birth, but just for 2 days, and quickly transitioned to room air and was very, very stable from that perspective. She was on caffeine, which is really common for apnea of prematurity, but that was able to be stopped at 34 weeks. Parents have 2-year-old twins who were born at 34 weeks, so they were familiar with the NICU environment, and mom strongly desires to breastfeed. So even before Lauren is ready to start feeding, there are many developmental principles that we keep in mind to implement to help make that outcome of feeding as successful as possible. So what are some of those principles? The biggest is providing positive pre-feeding experiences. So I want to go through some of the options to do that. As much as possible, we want to reduce negative medical interventions around their face and mouth. You already know that there are so many necessary things that we have to do to their face and mouth in order to keep them alive and keep them all supported. But having that be in the back of your mind of what can I do to reduce this or minimize the impact of this negative intervention. For example, if entering their mouth for suctioning or something else, if possible, trying to elicit the rooting reflex so the baby is a little bit more prepared and ready for something coming into their mouth. Using as little tape on their face as possible. The tape helps everything be very secure, but it's very, very noxious to put on and to put off. And even if you think about the stressors and the pressure around their face musculature that happens with the tape in a certain manner, that can proceed for a long time afterwards. Transitioning from an OG to an NG tube as quickly as possible. It's really hard to get that positive tongue stimulation and exploration when there is a tube that's tethering your tongue down, right down the midline of your tongue. So whenever that baby is safe to have that move to an NG, that's recommended. We really want to allow infants to explore their hands to their face and their hands to their mouth. So the number one reason that this isn't done all the time is because usually there are things in their face and mouth that need to stay there, and babies don't really care that that is necessary for them. So if it's not reasonable to have them be free and have them explore, it can be under a controlled, supervised setting. For a few minutes during each cares, let that baby get up there and explore their face and mouth. Even something as simple as allowing the baby to smell mother's milk throughout the day is another example of positive pre-feeding experiences. There's a significant amount of research that highlights the benefits of these and other experiences for babies, so I wanted to include some of those studies here. One of the main things is lots and lots of skin-to-skin time with opportunities to practice latching at the breast. We want that baby on that mama as soon as it's medically safe and for as much time as mom is able to do so. We want gentle oral care using breast milk whenever possible. Oral motor or sensory interventions. There's lots of protocols out there about specific interventions to do with the baby's mouth, but the big message is get in there, let the baby get in there, have some of that positive interaction. That includes that non-nutritive sucking, and I just mentioned there about the correct pacifier size, because there's so many times in the NICU when the baby starts out with the wee thummy, and then they kind of hang out with that wee thummy, even though they're now 37 weeks and totally ready to move on to the next pacifier. So keeping that in mind about when they're ready to graduate to the next pacifier size. So those are some examples of the pre-feeding experiences and some of the benefits that we get from them. So now a baby like Lauren has gone through this and is ready to start with feeding. What are some keys to keep in mind for that first feeding? In general, babies usually do best with their first feedings when they're around 34 weeks. But there's always that, I like to say, the one kid in the class that ruins it for everyone else, who's the 32-week star and just is a perfect feeder out of nowhere. So there are always some of those babies who are ready to feed a little bit early. But in general, those first feedings tend to occur between 32 to 34 weeks, depending on their clinical status and their cues. If mother's intending to breastfeed, a great recommendation is to try to have some protected breastfeeding time for about 3 days or 72 hours. If that baby's ready to feed, let's have the first experience of feeding be around breastfeeding. And then the biggest thing for me with thoughtful first feedings are the next 2 points. Having parents be involved in the decision to start feeding and at bedside to participate. I can't tell you how many times I've heard that a mom came in to see her baby just like she does every single day, and the nurse casually mentions, oh, she did great at last night's feeding, or we fed her earlier this morning and she did awesome. And it's just so gutting to that mom who has been waiting for weeks for their baby to get to the age that they're ready to feed, and they weren't able to participate in it. Now, the nurse who fed that baby was from a very well-meaning place. The baby was old enough, was ready, was cueing, but at what cost did that interaction happen to lose that first feeding? So I'm a big fan of constant conversations with families. Looks like she's getting ready. Let's kind of have a plan that maybe tomorrow, if you're here during the day when she cues, we can feed together. Now, for those first feedings, ideally, either the feeding therapist is present because we are able to sit and devote 45 minutes to nothing else, or the nurse is freed up to allow more time to devote to that session. The first feeding is not the time when a nurse can kind of be keeping an eye on neighbor who's been acting up all day long and is really kind of here but not really because she has to be split. So asking for help from a resource or charge as much as possible to really devote that time to the first feedings. And another big principle is setting expectations appropriately, remembering that the goal for first feedings especially is absolutely not volume. It's just to practice positive practice experience for the caregiver to learn techniques and the baby to start to explore feeding. So those are some thoughts on first feedings in the NICU. So Lauren's mom has a strong desire to breastfeed. So let's talk a little bit about breastfeeding in the NICU. Most of the NICUs that I've worked at, or nurses or therapists that I talk to in their NICUs, most places are striving to do better. There's always room for improvement, specifically for breastfeeding rates at discharge. There's lots of high breastfeeding rates of moms that intend to breastfeed and that start with breastfeeding. But when we look at breastfeeding rates at discharge, there's significant room for improvement. I think it's most important to have breastfeeding be part of the oral feeding progression at every single stage. We talked about in the pre-feeding, babies spending time at a breast, they're kind of exploring, first feedings for 3 days, having it be at the breast, and then breastfeeding being part of the conversation and part of the plan from that point forward. I think one of the hurdles to successful breastfeeding is often an underlying negative bias among staff related to breastfeeding, and I think it's important to kind of call that out and discuss it. This bias can be translated inadvertently through casual comments that become very powerful influencers for babies. And so those of you who work with me know I like to just tell it like it is, and so I wanted to talk about some of those casual comments that are not poorly meaning and poor intention that can really impact negatively breastfeeding. So, for example, moms hear a lot that it's easier for a baby to bottle feed than breastfeed. That's not really supported in the literature. Breastfeeding and bottle feeding are just very, very different. It depends on the baby and the mom, and it depends on exactly what's happening with each. And so it's not really fair to say it's easier to bottle feed than to breastfeed. A lot of times, the discussion becomes around numbers. We are a little bit obsessed with numbers, and so it's safer for us to know exactly how much he's eating. So to a mom, that might be translated as, do you want your baby to be safe, or do you want to breastfeed your baby? And so that's a very kind of clear leaning towards, I want my baby to be safe. And then the one that's probably the most common in my experience is a mom starts out with breastfeeding, maybe starts out with bottle feeding, and then the baby is doing a very appropriate slow progression in their feeding. But when you're in the NICU, sometimes a day can feel like a week, and it just doesn't feel like you're progressing. And then one comment at some point by someone is made that says, if you want to leave here quicker, we could just focus on bottle feeding. And then in my experience, that's it. You can just kind of throw breastfeeding out the window because mom will say, oh, we'll work on breastfeeding when we get home. Sometimes that works. Sometimes it works to get out of there and then work on it at home. The majority of the time, that's not the case. If a baby has not been continuing to practice at the breast, it's very, very hard to then start saying, okay, look, I'm a great breastfeeder now when I get home. So that's another one of them. And then I put this about the scale only shows 2 milliliters, because I think we can all agree, those of you who use breastfeeding scales, they're kind of, pros and cons of them, to put it mildly. And so it's really helpful to get good evidence sometimes about what a baby's transferring, especially when you medically need to know. But sometimes a mom and a baby can have just this beautiful session. They're latching so nicely. Mom is feeling more and more confident. The baby's really enjoying it. And then you go and put them on the scale, and it's like, oh, he just took 2 milliliters, or oh, he lost 20 grams. That's the best. And so kind of making sure to preempt use of the scale with a conversation with mom of, this is one point of data, we're going to collect this, we're going to see what it does, but I really want you to focus on the quality of this feeding. So using the scale with caution, I would say. So I know that another way to support breastfeeding in the NICU is by educating providers as much as possible on breastfeeding techniques. For me, when I started in the NICU, I felt very intimidated by helping a mom with breastfeeding. One of the reasons is I felt like if I didn't know everything about breastfeeding, who am I to help this mom figure out anything about breastfeeding? And so I hear that quite a bit. It's like, ooh, I don't really know how to help her. One of the things that helped me get started was some really concrete tools of a way to help a mom with breastfeeding. And so, of course, we don't have time to talk about breastfeeding for too long, but I wanted to share this one tip that really, really helped me and helped build my confidence in supporting moms. When you have a preemie or a small baby, careful positioning is even more important than if you have an older term baby with breastfeeding. So if you hand a mom a small preemie that's swaddled and ask her to breastfeed in the cradle position, which is what all those lovely pictures show that this is what breastfeeding looks like, there's very little chance that that mom and baby are going to be successful and get latched. That baby needs to get much, much closer to mom. So tip that works nicely, and I always tell moms, this sounds a little kooky, but hang with me, and then they usually really love it in the end. First of all, make sure that mom is in a well-supported position. You want to remove any barriers between mom and baby, including that swaddle. I find that the cross-cradle hold works really nicely. By no means is this the only way to breastfeed small babies, it's just one tool to have. And the part that's a little bit weird, but if they hang with me, it works, is tucking the baby's bottom underneath the opposite breast. Even if mom has small breasts, if that baby is tucked under the opposite breast, you're automatically having the baby come to mom's breast at a much deeper angle, especially with their lower jaw and tongue. So that tuck under mom's breast, I can't tell you how many times we do that, and mom goes, oh, wow, look at that. This is so much easier. And the other important thing is really good breast shaping. Small babies have small mouths, so they need the breast to be shaped in the same direction of their mouth. So that's often in a U shape when they're in the cross cradle. And in that cross cradle position, the input that mom gives is using her wrist against the baby's shoulder as opposed to kind of shoving the baby's head into the breast. So that's just one technique for facilitating a cross cradle hold with a small baby in the NICU that will hopefully help people get a little bit more confident if they're not already. So let's go back to sweet little Lauren. How did she do? Between 30 to 33 weeks, Lauren had regular skin-to-skin time with her mom. She was stable, she was on room air. Mom actually commented how wonderful it was to just have one baby in the NICU, because the last time she was in the NICU, even if she was doing skin-to-skin time, of course she was feeling guilty that she wasn't doing so with sister. And so they had amazing skin-to-skin time in the NICU. At 33 weeks, Lauren began latching to a recently pumped breast. And then at 34 weeks, she began eating. It began with just breastfeeding. She was feeding per cues. It was usually around twice a day that she would wake up and be interested in feeding. And she slowly started latching to a more full breast. Towards the end of the 34th week, she started practicing with the Dr. Brown bottle and preemie nipple, and she was feeding per cues. Over the next few weeks, as Lauren's feeding progressed, what we did is we prioritized breastfeeding. So 3 times a day at a minimum, she breastfed when she was hungry. If Lauren started to have energy beyond those 3 times a day, that's when she practiced the bottle. So for this mom, she was there during the day and went home at night. So Lauren learned to use a bottle with the night shift nurses, and mom was there during the day to help work on breastfeeding. She discharged at 37 and 3. And at that time, her feeding plan was breastfeeding ad lib, but she was small and she needed fortified feeding. So she had 4 bottles of fortified feedings during the day. And mom decided when to do either of those. I think this is such a great plan to go home on because it's so easy to make those adjustments. You have a baby who knows how to do both. If the pediatrician and the dietitian are happy with growth at home, hey, let's drop one of those bottles and then keep dropping that. And if she wants to just breastfeed at lib, that'll be the goal. If weight gain is not going great, the scale might need to be shifted in the other way. But that was a really positive outcome for sweet little Lauren, who most people would consider a feeder and grower and a really nice NICU feeding progression. Let's move on to our next baby. So Sophia had a little bit of a harder course. She was born at 31 weeks by emergency C-section due to placental abruption. She very quickly transferred to a higher level of care, not only for ventilatory support, but she was also found to have group B strep sepsis, and she was treated with 21 days of ampicillin. She then had progressive increase in ventricular size and head circumference, and she came to Children's and had a VP shunt placed at 35 weeks. Cranial ultrasound showed a grade 3 bleed on one side and a grade 4 bleed on another. During her time here at Children's, from 35 to almost 37 weeks, she had no oral interest, no sucking seen at all during therapy or with nurses. And this mom was not interested in breastfeeding. So now that we have a baby with clearly a little bit of a more complex neurologic picture, let's take a step back to look at some of the more basic components of feeding and why feeding can be so challenging, especially for a baby like Sophia. So this is a diagram from Lynn and Robin's book, and it's still absolutely true today. The goal is in the middle of effective feeding, and it just shows how complex it can be. Up in the corner is the baby's physiologic status, so their respiratory rate, their overall stability, and then the baby's motor skills. So Sophia not showing any suck, questionable swallow integrity, obviously that's going to impact her effective feeding. Down on the bottom right, those organizational abilities, the baby's ability to stay with you, stay alert, stay active during the feeding. And then this says parental attributes. I like to change it to caregiver attributes. Whoever's feeding the baby at that time, what's their emotional status? Is mom feeling pretty down, feeling anxious? Is the nurse who's feeding actually super worried about neighbor, so a little bit distracted? And then what are the skills and knowledge of the caregiver that's feeding the baby? And so all of these components impact each other and can impact effective feeding. This is to show what normal feeding looks like. The top waveforms are sucking, and the bottom waveforms are breathing, and the small triangles are swallowing. So it looks like this in a normal baby. Suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. It's very rhythmic. We say you can dance to the rhythm of a baby feeding. The baby stops sucking and takes a nice calm breathing break and then continues feeding. So that's the goal. That's what normal feeding should look like. What often happens is a baby is unable to integrate their breathing into the sucking bursts, so they decide to hold their breath, especially preemies. So instead, they just do suck, swallow, suck, swallow, suck, swallow, suck, swallow, suck, swallow. That may be when they start to desat, have a little color change. Finally, the baby stops sucking and then does some really big catch-up breathing. So we call that feeding-induced apnea. Sometimes in the literature now they're calling it suck-swallow uncoupling, which is a little bit confusing to me, but that's a visual to show what that is looking like. And then sometimes a baby is trying to get it together, so they have short sucking bursts. So here we got suck, swallow, breathe, suck, swallow, breathe, breathe, breathe. So it's kind of this in-between disorganized pattern that the baby is using to try to coordinate their feeding. So when I go to feed Sophia, I already know her history. I know she's not really sucking anything. I really want to optimize everything about her feeding conditions. So these are the things that I think about when I sit down to do that feeding evaluation. I think about what bottle and nipple am I going to use, what position am I going to put the baby in, and how am I going to use pacing to help the baby. So let's talk about how those things can influence a feeding. Many of those things impact the flow, how fast the baby is getting the milk. We know that the higher the flow, the more challenge to the suck, swallow, breathe mechanism. There's an increased likelihood of physiologic compromise, which leads to increased fatigue. The baby can't catch a breath, they're going to stop sooner so they can stop and breathe. A high flow puts an infant at risk for aspiration, even if swallow integrity is normal. We see this when moms breastfeed nice, normal, healthy babies. Mom has a big letdown, the baby's overwhelmed, coughs and chokes and pulls away. That's normal. High flow, even with normal babies, can impact coordination. And we know that alternately, a low flow allows much more time for breathing and feeding in a comfortable manner. So one of the ways we impact flow rates is with nipple choices. Here in our hospital, this is kind of the layout of slow to fast for nipple choices. I put the Binky Trainer as slowest because it can be used that way. You can help to manipulate it, so if the baby's sucking really hard, you can stop the syringe so they only get a little bit, or if the baby has a weak suck and any way you're pushing, you can help push just tiny amounts at a time. So it can be used as one of the slowest ways to give flow for the baby. A year or two ago, I don't know how long it's been, Dr. Brown Bottles came out with the Ultra Preemie Nipple. We found we've been able to reduce use of Binky Trainer since this came out. It's so nice and slow. It really helps those babies that you're concerned about their swallow or who are so tiny, like those 32-weekers that are ready to eat. I'm like, let me see if you're really ready, and I'll grab that Ultra Preemie Nipple to use with them. From there, it's the Preemie and the level 1. And then here we do have the option of the yellow Simlock disposable nipple, and beyond that, the 2, 3, and 4. So I'll just say two quick things about disposable nipples. One of the biggest things is they're really unreliable as far as flow rate. The same nipple can have a huge variance in how fast or slow the milk is coming. So one of the reasons that Dr. Brown's we use so much is because they're very, very precise. The way that they're made, every preemie nipple is going to be the same as the other preemie nipples. You can grab the yellow nipple or the infamous slow flow, and you just don't know what you're going to get, and the baby doesn't know what they're going to get. That's one of the concerns with disposable nipples. I said 2, but I actually have 3. The second concern with disposable nipples is it's not really translatable for home. So a baby that's so successful in a NICU with disposable nipples that are one-time use nipples, which cost about $1.15 per nipple, you send them home, even if you send them home with a bag of those nipples and there they go, technically that's only going to last for a few days if they use it correctly. And then the family is at home left with, okay, now what bottle does my baby use? So it's one of the reasons why often I have families bring in bottles that they've registered for or chosen at home to practice while they're still in the NICU, or we make sure we find a bottle that can be reused safely. Because the third thing that happens is families don't throw them away after one use. They continue to wash them and use them. And there's even been instances of the nipple falling apart and babies aspirating on small parts of rubber that come from these nipples. And so, as you can tell, I'm not a huge fan of disposable nipples. But, and the third thing, it might be 4 at this point, but last thing is if you take a bottle with a disposable nipple on it and just squeeze it, just compress, milk comes flying out. A baby does not need to use a nice, effective suck-swallow mechanism on a disposable nipple. Just biting and munching on that nipple, they get all the milk that they need. So you can only imagine how that translates to breastfeeding. Because if they go to mama with that biting and munching, not only is mom in pain, and that's no longer a positive experience, but they're not going to be able to help initiate the letdown and get mom. So there's lots of concerns with disposable nipples. So nipple choice is one that we think about, and then the second is what position am I going to use for the baby? We often use elevated side-lying position for feeding. It's just such an excellent position for young infants. It provides good postural support and stability for an infant so they can focus on their mouth. Often a partial swaddle added to that can help support it, and it really slows down the flow rate from the bottle. The reason it does is because it minimizes the impact of gravity on the flow. So just another visual to help with that. When a baby is kind of lying down and the bottle is upright against them, we've got gravity that is really contributing to how fast the milk is coming. In side lying, the gravity effect is minimal. Another option to kind of have a similar minimal effect of gravity is having the baby in a much more upright position so that the bottle is also then horizontal. The amount of support that a baby needs in this upright position, it depends on their age, on their head control, and on their general medical condition. To optimize feeding, as I said, we want to provide as much support as possible. Less support may help keep the baby awake, but we have to carefully weigh the cost and the benefit. So a third strategy that I have in my mind for Sophia is pacing. Pacing allows opportunity for the baby to breathe during feeding by interrupting the flow. So if you remember that diagram of suck, swallow, suck, swallow, suck, swallow, if you don't let the baby keep going all that way and run out of all their respiratory reserve, cut it off sooner by dropping the bottle down so there's no more milk, they can then transition to breathing much better. So for example, a baby who has that feeding-induced apnea where they're holding their breath, after 2 or 3 sucks, tip it down and let the baby catch their breath. One of the things you'll find is even after you tip it down, they're still finishing swallowing because there's still milk at the end of the nipple. Many people are concerned that if you tip it down and the milk is empty, if the nipple is empty, that the baby is swallowing air. You actually need liquid or food to initiate a swallow, and so when it's completely empty, the baby's just breathing out the air. So the times that they swallow air is when they're gulping, a combination of milk plus air. That's when a baby is swallowing a bunch of air. So for feeding-induced apnea, you tip it down after 2 to 3 sucks. If the baby just doesn't have enough ventilatory support or respiratory reserve, maybe let them go a little bit longer. Maybe it's that baby with a short sucking burst that's trying to catch a breath. They can go for longer, maybe 5 to 10 sucks, and then they can stop to get some really nice breaths. So just as a visual, the way it looks, so here's a baby that might do suck, swallow, suck, swallow, suck, swallow, and then tip it down to breathe, breathe, breathe. And then they've caught a breath or two, and then they go back to feeding. So that's one strategy, is pacing. As I said, it's a great technique that can improve the quality and the comfort during feeding. The goal is to maintain physiologic stability rather than respond to distress. You don't feed the baby till they deset and then tip it down. It's kind of against the point. And it's really wonderful to watch, but it really gives them that neurobehavioral practice to kind of start to get that rhythm. And within a feeding, you can start with pacing, and then the baby takes over and is able to kind of finish from there. So it's pretty awesome to see. There was a nice brief study that was done where they collected data on 18 babies that were traditionally fed, and once those babies were discharged, the whole nursing staff underwent some continuing education on how to provide pacing during feeding, and then they collected data on the next 18 babies. They were able to demonstrate statistically and clinically significant decrease in bradycardic incidences during feeding and improved sucking efficiency. So not only were they safer, they were actually better feeders. So I have a little video of a baby who is provided with pacing, and you'll be able to hear, so this is cervical auscultation that you see us therapists using quite a bit at bedside. It gives us a little bit more in-depth insight into the swallowing and the breathing that the baby's doing during feeding. See that nice deep breath that the baby does? Oh, thanks. Okay. So you can see that that baby is able to integrate their breath and then hopefully take over from there. So let's go back to little Sophia. So I sit down for this feeding evaluation at 36 and 6/7 weeks, and to my surprise, she is really interested in sucking. I don't know if it was just the ambulance ride to the other, transfer to the other hospital or what, but she was like, oh, thanks guys, she started sucking. So I was like, okay, you're sucking, let me get a little bottle. I was still pretty nervous, so I got the ultra preemie nipple, I put her in sideline, and I kind of did extreme pacing. I kind of only let her have 1 or 2 sucks and then quickly tipped it down because I was nervous. But in this manner with my extreme pacing, she was able to take 13 mils, and more importantly, she didn't have any Brady's or DSATs. She was calm, and I thought, okay, this baby is ready to start feeding. The plan that we made was for her to take 10 cc's up to 4 times a day using these techniques. I came back a few days later, and feedings were going okay, but she was having more Brady's and DSATs. And at that point, I trialed chilled liquids, and this seemed to improve her timing. With the chilled liquids, she was able to advance her feeding to taking 20 mils for 5 times a day and the plan was that she had to stay there until she could take those 20 mils without Brady's and DSATs. Once that happened, then it was possible to progress. So let's go back and talk a little bit about chilled liquids. It's something that's been used for adult population for quite a long time, and there's more and more research coming out lately, specifically by Ferrara out in New York. Cold liquids have been shown to improve swallowing safety in this nice pilot study. She found that the occurrence of deep penetration and aspiration decreased significantly with cold liquids compared to room temperature liquids. So I encourage you to kind of check that article out. Here's one little slide from that article that compared the incidence of aspiration, the percentage, with room temperature liquids versus cold liquids. And you can see that in the majority of the feeding of the subjects, the incidence of aspiration decreased. And like I said, she was able to get statistical significance. So that's a pretty exciting intervention and tool to have in our back pockets because it's really low risk. Some people are worried about, oh, doesn't the baby get too cold? And she's doing more studies, and others are doing studies about that it's a pretty low risk intervention, but especially in the NICU population, we've been using it quite a bit, and clinically, we find it to help. For example, during swallow studies, if a baby's having trouble, we might put some ice in the barium or quickly make some barium with chilled liquids, and we can see some improvements. So little Sophia was on chilled liquids, and she got it together, and she was able to advance to feeding for 20 minutes per Qs. She still needed the ultra preemie nipple. About 2 weeks later, or a week and a bit, I was able to advance her to the preemie nipple. She was taking a percentage of her full feeding volume, and then she kind of hung out there for a bit. I tried to advance her to the cradle position, see if she was ready for that. She just started coughing. I tried to reduce the pacing and leave the milk in there for longer. Unable to handle it, she was coughing. So we kept her at her really safe plan with preemie, sideline, chilled, and consistent pacing, but we were able to go up to 30 minutes for feeding. And she was able to get a little bit more of her feeding volumes in that manner. So again, about a week and a half later, she was ready to go home. She was fully feeding in this manner. Some nurses had trialed the level 1 nipple and really unsafe started coughing. We made sure family knew how to feed, and I scheduled a swallow study for her, and I scheduled that at 44 weeks. So let's talk about swallow studies. Videofluoroscopic swallow studies help us to evaluate the pharyngeal component of the swallow. During the study, you can trial different treatment techniques, which is great, but thoughtful timing of the VFSS is crucial. So you have to think, what question do I want answered right now? For example, the baby that I know for sure is unsafe for feeding does not need to go and have the radiation exposure to tell me that. She's clearly unsafe for feeding. If you're concerned about an anatomic abnormality like a TEF, the test that you want is an esophagram, because that will look a little bit more in depth at the esophagus. And so make sure you have a question that you want answered. You want to think about how will it change recommendations. You want to make sure that the baby can take a minimum. When Sophia was younger and there was no suck swallow and she couldn't take anything, some people might say, okay, let's go ahead and get a swallow study. And we have to say, no, thank you. She's unable to participate in a swallow study. It would not be valid at this time. And we really do not recommend swallow studies for infants under 40 weeks. The biggest reason for that is there is huge progression that happens between 37 and 40 weeks, for example. That is a time of significant developmental improvement and progression. It's a moving target, and it's really unfair to stop that target and say, okay, this is where you are. We don't repeat swallow studies frequently, so that's a plan that's made for about the next 6 weeks, for example. So Sophia is a great example. If we did her swallow study at 37 weeks, it would be one piece of information and would just really block her and look at all of that progress that she made after that. So we like to wait until a baby is 40 weeks. The limitations are it's just one moment in time, and as I mentioned, it's not designed to assess reflux or sending aspiration or some of those anatomic abnormalities necessarily. But Sophia did come back for a swallow study at 43, almost 44 weeks as an outpatient. She was still feeding in side lying, but we began the test in upright just to see, with a plan to go back to side lying if it was a problem. We used the premenipple like she was at home. She was a really good participant. Mom was the primary feeder during the study, so I have the study to show you. This is her feeding with room temperature liquids in the beginning of the feeding. Oh, sorry. There we go.
Thin preemie nipple.
I'm realizing I'm not giving you some insight here. This is the bottle nipple filled with barium that shows up as black, and then you can see her tongue is underneath. It comes back here. The first pocket here is a normal pocket to swallow, and then she goes down into the esophagus. The airway is here in front, which is obviously what we want to avoid, any milk going down there. So let's watch her feeding in the beginning. She has really nice timing. Everything's going the way that it should. We also look at, is the preemie nipple too slow? How many sucks per swallow? Looks really, really good, about 1 to 2 sucks per swallow, which is what we want. So what we do here, and at any place that's doing a really high-quality study, is we do fatigue samples. Because if you just look just at the beginning and look at the swallow, that just tells you what a baby can do with a little bit. As a baby's swallowing muscles get tired, their swallowing coordination usually gets worse. So we stop the camera, we switch from the barium to the baby's breast milk or formula, have those muscles get tired, and then switch back. So when we did that with Sophia and looked a little bit later in the study, we had this fatigue sample. So this is a good example of a baby who now has a swallow delay. If you remember before, it was just hitting the first pocket and quickly going away. Now it's hitting the first pocket and the second pocket, and this is an open airway. So a swallow delay is pretty dangerous for a baby to begin having laryngeal penetration or aspiration. So she started having a swallow delay with fatigue with room temperature liquids. It wasn't every single swallow, and she never penetrated or aspirated, but she continued to have that swallow delay in other videos as well. So remember, this was room temperature. We went ahead and offered her chilled liquids for her feeding, and let's see how that went.
Chilled thin preemie. She's doing great with it.
Even without being certified to read swallow studies, you can see that improvement of timing. Right away, I'll show you again just because it's exciting. Right away, she starts swallowing just from that first piriform sinus, and just that timing just improves so nicely. So just as a summary, she showed fatigue-related changes in her swallow. The room temperature moved quickly down, putting her at risk. The chilled liquids was better. And then the chilled was safe throughout the entire fatigue sample of her bottle. Do you have a question?
I do.
Okay.
Sorry.
That's okay.
Do you think, sorry, I'm just curious, do you think that,
I'm wondering, like, if the consistency, is the hot any thinner?
No. There
Okay.
may be a little bit, but not enough.
Okay.
That is one of the things that she's researching a little bit more of. I do think in general, I think it brings it slightly, but not enough to make it significant from a swallowing perspective. But yes, that's one of the questions that we're continuing to explore about cold liquids.
Okay.
Yeah. So when Sophia came back for that swallow study, we looked at her growth to see how this feeding was going at home. And this was her growth chart. The reason there's a big gap is because she wasn't here. She was at another hospital, but anyone would be really excited about this growth chart at home. So how does mom think things are going at home? When she came back for that study, mom thought things were going great. Sophia enjoyed eating. There was very little to no stress surrounding feeding times. Sophia was taking about 80 meals every 2 to 4 hours for 8 feedings per day. The cold milk was working well. She was able to keep it in a small refrigerator in the bedroom and took out a cool lunch pack. So this is a really good example of a baby that benefited from a really controlled, slow progression in her feeding. Lauren, we could just say, okay, PO per Qs, but Sophia really benefited from that little bit of micromanagement of let's do this, let's slowly do this, and slowly progress, and then what a great outcome at the end. Now we'll move on to Arjun. Arjun is a sweet little twin. He was born at 36 6/7 weeks. That's when everyone celebrates, hey, he should be fine. He was initially in the NICU for 4 days, just taking small amounts with a disposable nipple, and he discharged home with his twin. He was readmitted to the NICU after 3 days because he couldn't keep his temperature, he had poor endurance with feeding, and he wasn't taking enough. So I met him at 38 4/7 weeks, and right away I saw that he had a high arch palate, he had short sucking bursts, he was a very hyper alert baby. He was on guard during feedings, and anything that happened during feeding, it would kind of throw him off during the feeding. He benefited from a quiet room and minimal stimulation, and I recommended a preemie nipple at that time. About a week later, he was having similar feeding performance. He was really just struggling with feeding. He got sleepy very quickly, and mom started to have a conversation of, should we go home with an NG tube? I really felt like this was not something that was going to get better quicker and that it would benefit this family to go home with an NG tube. So we put that plan in place. We started to get our nurse case manager involved, get our home care set up, have our NG, have teaching set up. When I came back a few days later, everyone was very excited, because Arjun had progressed to a level 1 nipple, he was able to take his full feedings, there was no NG tube, and he was gonna go home, and wasn't this wonderful that he was going home on full feeding? When I saw him feeding, I had strong concerns. I had concerns about the quality of his feeding, I had concerns about his cues, and kind of being pushed to feed to meet those volumes. So just take a minute to talk about what I call momentum. A lot of times in the NICU or in the hospital setting, there's momentum that happens. This baby is getting better, he's gonna be going home on Monday, and that's what's happening. There's a momentum towards discharge on Monday. So it's very hard for a nurse that comes on shift who's watching a feeding and has concerns to stop that momentum, or a therapist who comes on to stop that momentum. And that was what happened with him. So what are some of those cues that he was showing to myself and nurses as well that showed some negative cues during feeding? Babies really tell us a lot with their face. If you watch their face during feeding, they might raise their eyebrows, they might blink a lot, they avert their gaze, they can have changes in their tone and kind of get floppy, and you can hear lots of wet breathing sometimes, difficulty with comfortably swallowing or breathing, so they might have stridor. So there's lots of those negative cues that happen. Why is watching their cues so important? As we already talked about, early feeding experiences in the NICU impact an infant and family's relationship with feeding far beyond discharge. There's lots of evidence to prove that babies, when they go home, will continue to have feeding aversive behaviors in either 30% or 50% of the babies. I'll just highlight one here at the end there that Damaro showed in 2011 that feeding problems were prevalent in both the early born and the later born babies. Those 34 to 36 weekers, they still had those problems at 3, 6, and 12 months. And that's where Arjun fell. He should have been fine at his age, but he continued to have those problems. So he comes back to see me as an outpatient 9 days after discharge. He had horrible growth the first week at home, but then he started picking it up and having some growth. What do feedings look like? He's feeding about every 2 to 4 hours. They've gone up to a level 1 nipple, either side lying or cradle. He quickly falls asleep during feeding, and so parents Significant stimulation is given even when he's just trying to catch his breath. The parents are so scared to lose him to sleep that this baby's just trying to go to catch a breath. Oh, come on, feed. Lots of things happening during feeding. So I tried, let's do level 1 nipple if he is in a sideline position, but if he's in cradle, he still needed the preemie, and I recommended a VFSS. But by the time we got to the VFSS, it didn't really matter. It was no longer about the skills for feeding. It was all about a feeding aversive behavior. He had really limited participation. He was pulling away. He really was unable to get a big sample during the study. We did see some of that delay, and for him, one thing that helped was having it be a little bit thicker, to half-strength nectar thick liquids. I suggested returning to NG. Family wanted to try thickened feedings first. So just briefly, I'll say that thickening is, the reason it works is because it provides a more cohesive bolus and slows the transit times, but all thickeners have pros and cons. It's really to be used with caution. With formula, you can use thicket or rice cereal. With breast milk, it'll just eat those things up and return to thin liquids, and so you're left with gum-based thickeners as an option, and there's an FDA advisory with Simply Thick. Here, we do not consider thickening as an option for infants under 42 to 44 weeks. Those guts are just not quite ready for it, and so it's really with the older infant that it becomes a discussion with the family and with the physician and medical team to make that decision. So what happened with Arjun? The thickening, unfortunately, did not really work. He transitioned to early intervention, home therapy services to work on his feeding. Continued to be a struggle over the next 5 months. He had difficulty with weight gain and respiratory illnesses. So I saw him again at a repeat VFSS that his team was requesting. At that time, he was 5.5 months, his goal was 4 ounces, and it was still taking an hour to feed. But the way that was happening was the first ounce was given by bottle with a level 2 nipple, and the next 3 ounces were given by syringe over a period of time. So he would turn his head, and he would get a drop of milk, and turn his head, and give a drop of milk. And the only way this baby was surviving was because mother and a teenage sister were doing this all day long, providing feedings with a syringe. So to most of us, that can feel very shocking. I will say that stories like this are not uncommon or unfamiliar to feeding therapists here or feeding therapists in the community. We know that families resort to these things with babies that are aversive. And so, obviously, this was very upsetting, and I tried to identify to family how they were doing this because they loved and cared for their baby, but it was a very dysfunctional feeding pattern that needed to stop. And I strongly recommended admission for an NG tube. It took 1 month, but mom finally did make the decision to come in to have an NG tube placed. It's a hard decision to make with a 6.5-month-old baby. The biggest reason she made it is because she saw twin brother who was playing and rolling and doing all of these wonderful things, and Arjun was not able to do any of those things. His whole life was about feeding. During this admission, an upper GI and then later CT scan revealed a vascular ring. It's a little hard to know how much vascular ring was impacting his feeding or not, but it was just one more reason that this baby needed support. He actually didn't even tolerate bolus NG feeds. He needed a continuous drip feeding. And then we made plans for a G tube placement and vascular ring repair. So Arjun is doing well. He is on a continuous drip for 20 hours per day. Things are going very well at home. He's not vomiting. He has excellent growth. He's happier. He's sleeping better. He's getting the nutrition he needs. He's still working on accepting some solids and working with feeding therapy for that. But the focus of family time is on developmental skills and just enjoying him as a person. I spend a lot of time with family talking about your baby's life is not all about feeding. They're about a lot of other things, but they are not able to focus on all of those other things when feeding is such a priority. So I think Arjun is an example of a baby where full oral feeding is not a goal that should have been reached. This baby needed NG support at multiple points along the way. I think you could argue the first NICU admission, he probably went home, let's see how this goes. The second admission, for sure, he would have benefited from going home with NG support, and then multiple points along that way. And so now we've got a baby that we really need to work on feeding aversion, and that's a much bigger struggle than if we would have otherwise. So that's little Arjun. Just as a summary slide, some of the strategies to keep in mind to optimize feeding. We want to provide those positive pre-feeding experiences. We want thoughtful first feedings, including the family. Offer opportunities for breastfeeding at each stage. Lean towards a slower flow with appropriate postural support and pacing as needed. Following those cues for starting feedings, but in my opinion, even more importantly, stopping feedings. And success of feeding should be in terms of the quality of the feeding rather than in volume or age of acquisition. Anytime someone tells me, isn't it great we send home this 34-weeker with full oral feeding? I'm like, maybe that's great. I'll tell you in a month or so. We really want to promote a team approach to oral feeding progression. Everyone has insight, the dietitian, the social worker, the nurse, everyone knows a little bit about what's going on with this baby, especially the parents, so having that team approach as much as possible. And my goal is always helping the parents feel comfortable and confident in feeding their infant, setting them up for increased success at home. So there's my presentation with a cute little former NICU guy. I'll be happy to take any other questions.
As well.
I read somewhere that left sideline, because of the anatomy of the vocal cords, was easier for babies to swallow. Is that a true thing, or just a?
So it depends. The vocal cord, sometimes it's because of the pulmonary vasculature and like the right upper lobe, but I think often we use left sideline because most people are right-handed. And so I put them on whichever side. I ask mom or dad, which hand do you use to write? And so they can hold the bottle with the hand that they write from. If a vocal cord is not working, might be switching it to one or the other side, depending on that, so, yeah. Any other questions? Yes. Nancy and Don.
What about the prolonged NG use, like beyond term, and is there a point where that becomes a negative to oral feeding?
Absolutely, and I
And
think
how
that
do you judge when that is?
when that is. So I think that part of that is a little bit geographical. There are many places around the country where babies do not go home with NG tubes at all. And so if the baby isn't able to get to full feeding, they get a G tube. Some places you get a G tube and a Nissen before you go anywhere, because that's just what's always done there. So when I first came to Seattle Children's, and that's where one of the places I came from was that. I was kind of surprised about how many people were going home with NG tubes. And I would say 10 years ago especially, it was really unacceptable how long babies were staying on NG tubes. So I think there's been a lot of work done recently, and I do think that idea of if it's going to be 3 months or longer, then they need to transition to a G tube. And so I think that 3 months is enough of a time to kind of let them progress developmentally. One thing is, when does the 3 months start? Was it back when they were preemie or back from now? I usually kind of say, okay, from now, if it's going to be 3 months or longer, then let's start getting the ball rolling for a G tube, because as you know, that doesn't happen quickly either. And so I try to have families start learning about G tubes, especially if I'm leaning towards this baby will need that. But absolutely, prolonged use of an NG tube can limit progression of oral feeding for sure.
Anybody else have a question? Yes.
So earlier when you were talking about positioning, so when you explained to the mom to hold the baby on the breast, you can tuck the feet under the other breast?
It's actually their little bum usually.
Okay, okay.
The baby's
Okay.
bum is underneath, and the feet are kind of here. So I wish I had a doll here to show you, but it works really, really nicely. And especially if you then support the family and get them all tucked in together, that position works really great.
And then you mentioned something about a U shape. What were you referring to?
Yes. So our natural position, if we're going to go shape our breasts, is to come in like a C shape. And if a baby is in cross cradle position, their mouth is going this way. So you have to change it from a C to go all the way under like a U to line up with the baby's mouth. Otherwise, it's like taking a sandwich and going like this. Very hard to eat a burger like that. So I like to kind of think of it as like a burger that has to line up with the baby's mouth wherever the baby is. So that C shape, I can't tell you how many times, keep going, keep going, keep going, because it just feels a little bit unnatural at first.
Thank you.
Yeah. I also like to tell moms, this is not the rest of your life. This is just right now while your baby is this little. You're not going to have to do this for the next year if you want to breastfeed. It will get easier. So. Okay, great. Thank you guys so much.
Yes, thank you so much. Thanks for coming.